Congenital cystic diseases of the lungs have an embryological explanation. These diseases may occur in adults in three ways: as surgically corrected pediatric cases with loss of lung tissue, expectantly managed pediatric cases who reach adulthood, and unrecognized cases presenting in adulthood or discovered coincidentally. Pulmonary development occurs in 5 stages. The embryonic stage is characterized by the appearance of the respiratory diverticulum on the ventral aspect of the foregut on the 22nd day of life. By the 24th day, the tracheal bud elongates and separates from the esophagus due to the presence of growth factors in the surrounding mesoderm. Failure of this process may result in the formation of a tracheoesophageal fistula, rarely reported in adults. On day 26, the respiratory diverticulum bifurcates due to the formation of a signaling gradient in the surrounding mesenchyme. Translocation of tracheal mesenchyme may result in suppression of a lobe which has been described in adults. On the other hand, translocation of bronchial mesenchyme may result in formation of an accessory lobe, a fairly benign condition. Asymmetric branching in the 5th week of life results in the formation of lobar bronchi. Segmental branching in the 6th week results in the formation of tertiary bronchi. The endoderm forms the epithelium, while the surrounding mesenchyme forms cartilage, muscle, and connective tissue. Formation of pulmonary vasculature and regression of the systemic plexus occur simultaneously. The pulmonary arteries develop from the 6th aortic arch by angiogenesis. The distal vasculature forms by the process of vasculogenesis. The two are connected by a lytic process. The pulmonary plexus is initially connected to the systemic veins. Connection with the pulmonary veins is established later. Clements and Warner have proposed a unifying theory to explain the embryological origin of bronchopulmonary malformations. According to this theory, a minor insult to the developing airways with normal development of vasculature results in the formation of a bronchogenic cyst. An alternate theory is formation of an abnormal bud from the primitive foregut. This adult patient showed a unilocular cyst. Grossly, the cyst wall had a glistening rugose appearance. Microscopically, it was lined by pseudostratified ciliated columnar epithelium and showed bronchial cartilage in the wall. This was consistent with a bronchogenic cyst. Arrested pulmonary artery growth with development of the bronchial tree supported by systemic vasculature results in a sequestration. These are invested by their own pleura and may be intra or extralobar. This cyst had a characteristic multilocular appearance consistent with an extralobar sequestration. On the other hand, this mass appeared unilocular. A solid area was identified on gross examination. The cut surface was multilocular. Microscopic examination showed a respiratory lining, inspissated secretions, and cartilage. The second stage of pulmonary development is the pseudoglandular stage, which is characterized by branching morphogenesis. The steps are budding, elongation, widening of the tip, and its bifurcation. This occurs in weeks 7 to 16 and results in the formation of the terminal bronchioles. Respiratory bronchioles and alveolar ducts appear at weeks 17 to 27 in the canalicular stage of development. Disruption of the tracheobronchial connection with continuation of the pulmonary artery supply results in congenital pulmonary adenomatoid malformation. This lesion had a solid cystic appearance. It was poorly delineated from the adjacent normal lung, and microscopic examination showed multiple cysts with bronchial lining, inspissated secretions, and surrounding inflammation. This was consistent with a CPAM. The saccular stage of development, which occurs in weeks 27 to 40, with the appearance of terminal sacs which bulge into the capillaries. The alveolar stage continues after birth and results in the formation of alveolar sacs with thin walls which facilitate gas exchange. Defects in cartilage with air trapping produce congenital lobar emphysema. We hope that increased understanding of lung development and the pathophysiology of congenital cystic lung diseases will result in the development of better strategies for their prevention and treatment in children and adults.